Hello, everyone. I'm Dr. Jackma with New Hope Fertility, and you're joining us live today for 12:30 Lunch and Learn. I'm gonna wait a little bit. I know we're supposed to start 12:30, so I'm a little early, and that's because I just wanted to make sure that the connection was great, and we'll wait till 12:30 to actually begin. So, in the meanwhile, hi, everyone. Let me wave back at all of you. Hi, thanks for joining. Ben Singer and John, we have so far. So, as I mentioned, we're just going to wait a little bit so that people can log on and we'll get all started. Hi, Amanda. Just going to wait a little bit, okay? Just one more minute and then we'll all get started. I hope everyone is having a great Saturday so far. I know I am. Yes, we are indoors. Yes, we are being safe because of the virus, but doesn't mean that you don't have to have fun, okay? So all of that is what we're going to talk about today. Hello, Canon. Hello, Ilario. Obviously, I have to call you by your Instagram name. Hi, Miss Checks. I hope all of you are having a wonderful Saturday. Oh, thank you. I woke up like this. Hi, everyone. Hi. Just gonna give it a few more seconds before beginning today's session, okay? Welcome to New Hope Fertility's Lunch and Learn session. And thank you all for joining us today. So I'm going to begin. So I am Dr. Janelle Jackman. I'm one of the physicians at New Hope Fertility Center. And today we're having our Lunch and Learn series as per usual, 12:30. I know some of you would have expected Dr. Zhang. And he will be resuming Lunch and Learn from next Saturday. But today you have me. Okay. So if you do not know me, I am from Trinidad and Tobago. I always sport my Trinidad and Tobago earrings, always. And I migrated to the US to do my OBGYN residency. And I've always had an intense passion for reproductive endocrinology and infertility. I am working at New Hope Fertility Center right now. And we are trying to put on these series. We know that everyone is home, and now is like a really good time to get to know everyone, that you get to know all the physicians, and that you're able to have these sessions to learn more about infertility, about reproductive medicine, about how we are here for you and how we can help you on your journey for your fertility goals, okay? So we are so happy that you can join us today, and I hope that you learned something from this session. So a little bit about my background. As I said, from Trinidad and Tobago, that's where I did medical school. That's where I did my initial internship. In Trinidad, the system is a bit different from the US, where we can go immediately from secondary school, which is equivalent to high school, straight into university. So I went from secondary school straight to med school. So I graduated from medical school at a pretty young age. I was 23 when I graduated from med school and began working as a doctor in Trinidad and Tobago. And in Trinidad during med school is actually when I fell in love with reproductive medicine. So we had a session on several sessions actually on reproductive medicine with our fertility specialist in Trinidad, Dr. Minto Bain, and I was absolutely in awe. So after I graduated med school, I started working with Dr. Minto Bain, volunteering actually with Dr. Minto Bain to learn more the background of reproductive medicine. And then I set off on my path to the US to pursue this as my goal. I did my residency at the Brooklyn Hospital Center. And then I started to focus on reproductive medicine since then, and I've started working with New Hope Fertility from last year. So if you've come to the clinic before, most of you would have probably seen me for the past year. And you meet me a lot in the OR. I spend a lot of time in the OR. I do, the egg retrieval procedures, the embryo transfer procedures. So a lot of you meet me there. A lot of you know me as the doctor, the positivity doctor. Some people call me. The other people call me Dr. Jackman, Dr. Jackie, sorry, Dr. J. I have a lot of nicknames there. Also, the makeup. As you can see, I love makeup, but this look, I woke up like this. This is just how I roll out of bed every day. So yeah, so that's my little journey and path to here so far. And, I still have way to go on my journey. We're always learning. We're always, doing more. So it's so good to be here with you guys today. So today I wanted to touch a base and do a whole myriad of things. We're going to talk about a lot of things in this time with together, and just see what we can get out. If anybody has questions, feel free to ask. From my first session to now, I've learned a lot about Instagram Live, so I do know how to see the questions and how to respond to it. So I'm much more savvy than I was the first time I did a live on my own account. And also you can find me at Janelle M. Jackman MD. That's my personal Instagram account. So you can always find me. I have some educational videos, and I'm going to continue making the videos. So you can always find me. So one of the first things I want to touch on today, as I said, it's going to be a mixture of topics. And if you have something you want covered, just feel free to put it in the comment section and I'll see it. So the first thing we're going to touch on today is at-home IVF. So a lot of people have been asking me what exactly is at-home IVF. It's, as the name suggests, exactly as the name suggests, IVF that you can do at home. The only part, obviously, that we cannot do for you at home is the actual egg retrieval part. But the entire medication and the stimulation part, you do at home. So we do have these kits that, once you qualify for at-home IVF, we can send you one of the kits, and it contains all the medication. It tells you exactly how to take it, which day to begin, which day to end. Everything is in detail explained to you how to do the kit. And basically, if when you follow the kit, we will then schedule you to come in for the procedure. So the only time you actually have to come in to the office if you do at-home IVF will be for the actual retrieval. So who exactly is a candidate for at-home IVF? Well, more or less any patient who is interested in doing egg freezing, in doing embryo freezing, in doing a fresh IVF cycle. They're all candidates for this kit. So if you're interested, let us know. We know that during this time with the COVID-19, most people are in their houses, as they should be, and we thank you. We thank you. We thank you for staying home. If you're an essential worker and you have to come out, we also thank you a lot too, because you're doing your part. So everyone is doing their part. In New York, we have seen a dramatic reduction in the number of people who are outside, and we thank all of you for staying indoors or working if you have to. So this kit is appropriate for that because you do the entire thing at home. You don't have to come for monitoring. You don't have to come for blood work. We send you all the instructions, and the only time you'd have to come in, as I said before, would be for the actual procedure. So if you are interested in something like this, then obviously you can just contact our office, make an appointment with one of the doctors from now till, from March straight to April 15th. We are offering free phone and video consultation. It's a perfect time to take advantage of free phone and video consultation. You can call the office and make an appointment to see me or any of the doctors you choose, and then we can go in depth about your particular case and what the best option would be. So I would say that this is a perfect time to take advantage of this service from us, because many people have questions. Many people don't know where what they should be doing. Many people don't know much about infertility and the next steps, and many people haven't even been considered this, because honestly, And I would fall into that category too. As gynecologists, we spend a lot of time basically coaching our patients on how not to get pregnant from very early on. You talk about contraception, condom use, IUD, birth control pills. We spend a lot of our lives avoiding pregnancy, and we never really plan for pregnancy when when you actually want it. So this is a great opportunity now to like ask your questions, figure out all the questions that you've had burning inside of you. If you've been struggling with trying to get pregnant, now it's a good time to find out next steps, find out what you can be doing to improve your health, to improve your overall being as a person, just to get through this. So that was on the IVF, the at-home IVF. If you have any questions, just let me know and we can talk about it as we continue. But that's in a nutshell what the kit contains, and we have no injections in the kit. They're all tablet medications, and your trigger medication is actually an inhalation. So there are no injections in the at-home IVF kit. So for anyone who is afraid of needles, this kit might also be a great kit for you. I think that's it in a nutshell. So I want to also move on now because I also mentioned about egg freezing. So egg freezing has become a more popular concept and things that people are looking into in recent times. And that's because initially a couple of years ago, it was thought to be experimental and or just for people who were doing fertility preservation because of a medical condition. For example, cancer, or they had something with the ovaries that they were going to remove the ovaries. So egg freezing used to be, thought to be just for them. In recent years, however, we have been able, we as in the IVF community, have been able to make egg freezing an option for anyone who wants to do fertility preservation for their own personal reasons, even if it's just because you're not ready to have children. So with egg freezing, you are literally doing the initial step, which is to create follicles. Each follicle has eggs, and then you come to us when the eggs are ready, and we will extract the eggs from you by transvaginal ultrasound and a Minuteer procedure. And then with those eggs, we're gonna freeze the eggs. So regardless of your age at the time of egg freezing, your eggs are going to be frozen at that stage. So we know that in terms of fertility, a woman's fertility is highly, highly dependent upon her age, but not necessarily her own personal age, but more importantly, the age of her eggs. Meaning, if you are 20 or 30 and you freeze your eggs at this stage, that's the age your eggs are being frozen at. If you freeze your eggs at age 40 or age 50, your eggs would have been frozen at 20 or 30, and you're still using the egg. It's like if you're being a donor for yourself, you're using the egg of a younger woman, even though it's yourself egg, and the chances of you being able to get pregnant using younger eggs would be higher. So egg freezing is a great option for any woman who may be going through any sort of medical treatment that may affect your egg quality or the number of follicles you can make. Any chemotherapy, radiation therapy, anyone who has surgery on their ovaries because of cysts or endometriomas. But it's also a great option for you and me who just may not be at this moment ready to have children, or, women right now, we're focusing on our career. Sorry, and our education, and these things might delay our fertility goals for a bit, and therefore egg freezing is a way that we can preserve our fertility till the time we want it. Is it 100% guaranteed that when we're ready to use our eggs, that all the eggs would be able to be fertilized? Well, no, we can't guarantee anything 100%. Remember that fertility is not just us, it's not just the eggs, but it's also a combination. You also have the male factor with the sperm as well as the combination factor. So there are many factors that go into fertility, but just know that there are options for people who may not be ready to have children, or may not have time, finances, or for whatever reason or may not have a partner. So there are several reasons why you may not opt to have a child or may not be able to have a child at this moment. And egg freezing might be an option for you. So you can ask us more about that as well. I'm just going to pause a minute just to see if anyone has had any questions that I can address. And if not, I will just continue. So I'm just scrolling down to see. And it doesn't look like anyone has any questions so far. Oops, I almost canceled, sorry. Yeah, so no questions so far. Oh, yes, there is a question from, that's Mang. So what do I physically have to go through? Is this with respect to egg freezing or with the home IVF kit? If I want to do egg freezing. Perfect. So we have a question. What do I have to physically go through if I want to do egg freezing? So personally, at New Hope Fertility Center, we do have different methods. So I'm going to go through quickly a basic menstrual cycle. And if you want it a little more in depth, you can look at my Instagram page where I speak about it just a little more in depth, but now I'm going to go quickly. So basically in your menstrual cycle, you would start off at the end of a period or menses. And that's when your period begins. The first day of your period is actually day 1 of your menstrual cycle. So if for any reason you ever hear us talk about day 1, that's the day you begin your bleed in your menstrual cycle, in your period. So in the beginning of your menstrual cycle, your brain is producing FSH, and that's a hormone that tells the ovary to create follicles. The follicles have eggs in them, and that's the way the brain communicates. The ovary then produces the follicles, which have potential eggs, and that will signal to your brain with estrogen. So this is the simplified version of the menstrual cycle, obviously. So FSH from the brain, FSH in the brain tells the ovary produce follicles. The follicles respond by the ovary responds by producing follicles, and the follicles produce estrogen that signals to the brain, yes, I'm responding. That goes on for a while until one follicle becomes dominant. It means it's the biggest one that takes over. The others grow at a less pace, and the dominant follicle gets more receptors to receive the FSH. That eventually will signal to the ovary, okay, we don't need follicles anymore, so we can stop the FSH, and LH will make you ovulate. So LH is produced, and that allows the egg inside that dominant big follicle to get mature. And the last step of this process, the egg is released from the follicle, and the follicle ruptures to release the egg. This is then picked up by the fallopian tube. If there's sperm because you had sex before, if you have sex after in time, then you can potentially fertilize that egg and get pregnant. That's a very simplified menstrual cycle, okay? How fertility intervenes, for instance, for egg freezing or even IVF, but we're speaking specifically of egg freezing right now, is that when your body wakes up and recruits all these follicles, and that's something your body can do. So the number of follicles depends on your age and your ovarian reserve. So a young patient with a high ovarian reserve might produce 20, 30, 40 follicles in the beginning of their cycle. An older patient with a lower ovarian reserve or somebody who has diminished ovarian reserve might produce, less follicles, less than 5 or 5 follicles. How many ever follicles your body recruits? When we intervene in IVF, we give you medications that will stimulate as many as those follicles that your body wakes up or recruits, as many of them to get large and dominant. So we don't want to select for one, which is what naturally happens with your menstrual cycle. We actually want to get as many of those follicles big. So there are 3 different ways. Well, there's several ways that we can do this. We can give you tablet medications that tell your body to produce more FSH in different ways, or we can actually give you FSH injections. So for egg freezing, this part is egg freezing and IVF. This beginning steps are the same. The fact that we're going to give you medications to get you more FSH, either by your body producing more FSH, or we actually give you FSH via injections. And this helps to get all the follicles that you've stimulated, that you've recruited to start growing, we're going to get all of them to become as dominant as possible. So if before your body would try to get 1 naturally, if your body recruited 10 follicles, we're going to try to get the 10 to be dominant. Then we give you a trigger medication. We don't want your body to be triggered on its own, which it will do if we let it. And that's because we need to time when to retrieve, to do egg retrieval, because we're trying not to get you to ovulate and rupture and release all these follicles into your body. We actually trying to get you to time it so that we can get the eggs out of your body so that we can intervene. So we give you medication to make you ovulate. We have two options that we use. One medication releases your natural LH, which is what I said before, will cause you to ovulate. The other medication pretends to be LH. It's actually beta HCG, similar to the pregnancy hormone, and that will cause you to ovulate. So either which medication we use, you will begin the process of ovulation. So why we need to give you this medication is because we want the egg to be mature. Remember, I said that's one step before you actually rupture the follicle. And we want the egg to be released from the follicle wall, and we want it to be in the follicular fluid. That way, when we come to retrieve, typically around 36 hours after, we would do a transvaginal ultrasound, and we have a needle guide. So we actually put the needle through the ultrasound, and we're able to go directly into the ovary and into the follicle and get all the eggs from each follicle. Not all follicles would have an egg that is easily released, but we try to get as many. So in my example, if you had 10 follicles recruited by your body at the beginning of your cycle, we give you medication so that instead of one becoming dominant, we get as much, maybe all 10 becoming dominant. And then when we do the procedure, we try to get all 10 eggs from each follicle. And many people will do this procedure asleep. We have the option to do it awake and asleep, depending on how many follicles, how easy it is to retrieve, and your pain threshold. So once we get those eggs, in terms of egg freezing, because that's the question, this is where it differs from IVF. Once we get the eggs in egg freezing, we do a process called vitrification, which is to freeze the egg as is. So we replace the fluid with a special medium inside of the egg, and then we flash freeze it. It freezes just like glass crystal, exactly with how it is. It's not like a slow freeze, because if it's a slow freeze, what we used to do a couple of years ago, the fluid expands and it can denate and rupture the cells. But this is a fast vitrification process, which the egg freezes exactly how it is, and your eggs are good until you're ready to use them. So if you do this in your 20s or 30s and you decide to use them in your 40s, 20 years later, 10 years later, your eggs are still going to be good to be used and be fertilized if you need it. So the basic process, what you have to physically go through, now to address the question directly, what do you have to physically go through for egg freezing process? Well, step one, overall health. I always preach that. But once you start that process with our process, what you're going to go through, you're going to have to take medications to help grow as many follicles as possible. You're going to take a medication to begin the ovulation process, and we are going to intervene because we don't want those follicles to actually rupture and ovulate. We're going to intervene after 36 hours before you actually ovulate the follicles, and we're going to retrieve the eggs. So the way to do this process, as I said, like there is a needle-free option where all the medications you have would be given to you via oral or nasal spray, and there are other options where you would have injectables. It just depends on your preference and the baseline number that you start off with. So I hope that answered your question. If you have any more questions relating to that, you can just follow up with it. Okay. I'm seeing another question. What is a normal number of follicles cycling in your late 30s? So this is from Genomic Prediction. Good question. So the number of follicles, the number of baseline follicles, as we know, it varies depending on the age of the woman. So a person in their late 30s. Now, it's difficult to give like a standard answer because a lot of it also depends on your background as well as your overall health, as well as what your ovarian reserve is. But a person in their late 30s, we can expect anywhere from 10 to 20 follicles developing once you cross over. So we have like different timelines of age when it comes to reproductive medicine. So in your 20s, you obviously would have the most potential up to like around age 35. So at 35, what we call advanced maternal age, and I never really liked that term, even in obstetrics. But anyway, at 35 is where we have our first rapid decline in fertility, and that goes from 35 to 40. At 40, the decline gets a little more precipitous, and then once you go beyond 40, as we go beyond 40, you know that the number of your reserve goes down. So a young patient who's young, healthy, in their 30s, between, let's say, 35 to 40, we can look at a reserve anywhere from, like, realistically, most times like 10 to 15. Some patients can have more, especially if you have like a background of polycystic ovarian syndrome. Definitely, we do see an increase of follicles in that syndrome. So it just really depends on your individual background, but I would say anywhere between 10 to 15 is like a realistic number to expect. Can CoQ10 be of benefit? CoQ10 is said to be beneficial, particularly in women who have diminished ovarian reserve. So diminished ovarian reserve is a definition basically in any patient who has less than the expected number of follicles that you would expect for their age. So we're looking at patients who have follicles of like 5 or less in the ovaries, and this is like a cumulative number. So once you have less follicles in your ovary and you've been diagnosed with diminished ovarian reserve, or some patients have quiet ovaries, meaning that we don't even see follicles developing, then CoQ10 is said to be of some benefit to take. If a regular person who has the normal amount of follicles take CoQ10, it's not going to be harmful, but you may not necessarily see any benefit to CoQ10 with using, CoQ10. So we touched on egg freezing, follicles. Any other questions? Or if not, I'm just gonna go on. So when we talk IVF, it's more or less similar to the process that you take. Seeing that there was a question with egg freezing, once we're getting into IVF, the process starts off very similarly in IVF as it would for egg freezing. So you take medication to grow the maximum amount of follicles that you can. Then you take medication to trigger yourself, which is to release, to mature the egg and to release it into the follicular fluid. The last step would have been to ovulate and to rupture that follicle, but obviously when we're intervening, we try for that last step not to happen. We extract the eggs just like we would for egg freezing. At egg freezing, once we have the eggs, this is where the process stops and we freeze your eggs exactly as is. In IVF, we now fertilize the egg. So to fertilize the egg, we obviously would need sperm, and sperm can come from your partner, your husband, or donor if you don't have a partner. So we now take the sperm and we fertilize it with the egg. In New Hope Fertility, we have two different ways that we fertilize. We have conventional fertilization, which is basically you put the egg and sperm in the dish and you allow the sperm to find the egg and to penetrate on its own. A lot of our patients, however, we do ICSI, which stands for intracytoplasmic sperm injection. And with this process, we will, under microscope, select based on physical characteristics, the best looking sperm. So we look at the shape of the head, the tail, the ability of the sperm to move forward and progressive, and just look at the overall how the sperm looks. And we select that sperm and we pick it up and inject it directly. So 1 sperm per egg is what we need for ICSI. And the reason why we do this at New Hope is because our testing is a non-invasive format in terms of genetic testing. So some patients opt, when they make an embryo, they want to do genetic testing. So you grow the embryo for 5 days after injection and after fertilization, And for us, if we're going to do our non-invasive testing, we do ICSI, which is injecting 1 sperm into the egg. And then we grow for 5 days. Sometimes if we don't get blastocysts, which is the stage we expect at day 5, we leave it for day 6 or day 7. And then we're able to do genetic testing on that embryo. So once again, there are 2 ways we can genetically test at New Hope Fertility. There is the conventional testing, which is a biopsy. So when you have an embryo forming and This is my embryo. Maybe I can draw it. Don't mind my drawing. So when you have an embryo forming, there's an outer layer that forms called the trophoectoderm, and then there's an inner cell mass. So this is my drawing. This is your outer layer trophoectoderm, and this is what is going to form your placenta and membranes. And then the inner cell mass is here, and this is what is going to form your actual baby. So when you do conventional biopsy, what you're doing is that you're going to make like a little hole in what we call the zona pellucida. Think of it like your shell of the egg, of the embryo in this case, because the embryo is already formed. And we allow a little bit of the trophoectoderm to come out. And then we take a laser and we take about 3 to 5 cells when it's out. And that's the traditional biopsy. And this is what most IVF centers would use. Probably 99% of centers use this method. And we do use this method as well, especially if we're going to do diagnosis on your embryo. For example, if you have a known conditions like cystic fibrosis or something that runs in your family with the your family line, and you want to test the embryo for it, we will do this method. Another method that we do is called the non-invasive method. So once again, we have our whole embryo. We did not make that whole. We didn't do the biopsy, and the embryo grows in a special medium. All embryos, regardless of how you fertilize it, it grows in a special medium to make it grow, and this always secretes DNA from the embryo. So at New Hope, most of our patients, we do what we call non-invasive chromosomal screening, and therefore we take this medium that is secreted into the we take the DNA, that's secreted into the medium, and we analyze that, and we're able to do what is known as like PGTA, testing for aneuploidy, and this tests for the number of chromosomes found in your embryo. It should be 46, 23 from the egg, 23 from the sperm, so each parent contributes 23 chromosomes, so combined it will be 46, and therefore for us we have to do the injection of the sperm, so that medium will only have 1 sperm, 1 egg. If we did conventional fertilization, then you can have a lot of DNA contaminated from the other sperm that didn't fertilize. So for this special non-invasive chromosomal screening that we do for genetic testing to tell if your embryo has the right number of cells, we do intracytoplasmic sperm injection in order to make sure that it's just 1 egg and 1 sperm. So there are many different options that we offer, honestly, that varies a little differently from what you normally get in conventional IVF, but it's just as good. Actually, the non-invasive chromosomal screening we find to be actually superior to the traditional biopsy. So we have many different options to suit our patients and like what their preference would be. Yeah. So I'm going to look again and see if I see anything. Any questions? And you can always stop me. Sorry. You would see my eyes diverting to the left too, and that's because I'm also using my computer to see bigger, okay? So please excuse me that you would see me looking back and forth, okay? One second. You can ask questions in the meanwhile. I'm just logging on to Instagram from here. Which obviously is taking longer. Okay. Okay. What do you think about an AMH of 0.5 with 33-year-old? So a 33-year-old with a level, an AMH level of 0.5. So before I answer the question directly, I'm going to first, sorry, explain what anti-Mullerian hormone or AMH is. So AMH is basically one of the tests that we use to assess a woman's ovarian reserve. So the good thing about using an AMH or anti-Mullerian hormone is that this can be done at any point in time in the menstrual cycle. We don't need to wait for like cycle day 3, which is when we tend to do like FSH or follicular stimulating hormone. However, if we use like AMH, FSH, and your antral follicle count, the number of follicles you actually have at the beginning of your cycle, then put together that these all can give us a combination of like the picture depicting the overall fertility picture. Okay, I would preface before I answer is that AMH tend to go in the opposite direction of your age. For example, as your age starts to increase, the AMH will start to go down, indicating that, you know, age-related natural decrease in your ovarian reserve does happen. So we tend not to like to use AMH as a prediction, like to say how fertile or unfertile someone is, because to be honest, the only way we can truly test if you can and will get pregnant, and this is going to sound so silly, is really for you to get pregnant. These tests we use as support, and AMH and ovarian reserve testing is really used to support to see if we do fertility treatment and how well you would respond to like the fertility treatment and medication in terms of like producing follicles and being able to reach the retrieval. However, it doesn't tell us your actual ability to get pregnant. Even if your AMH is high, it doesn't mean that you will get pregnant, and even if your AMH is low, it doesn't mean that you would not get pregnant. So we don't want you to think of a low AMH necessarily as that's it for fertility. But if a 33-year-old, has an AMH of 0.5, it is low for that age group. So you would come under the classification of a diminished ovarian reserve. With that being said, it doesn't really tell us that you are unable to get pregnant or you are able to get pregnant. It really doesn't say that. It just says that, you know, your response to fertility treatment will be less robust than someone who has a higher AMH. So, I mean, if this is like value for you or for someone you do know, hope is not lost. Just know that you probably would not produce 20-30 eggs or follicles when stimulated. It may be way less, might be 4 or 5. However, if you have just one good follicle, one good egg from that whatever number you produce, you are still able to maybe produce an embryo and still have chance of getting pregnancy and having a child. I hope that answered your question. If you have a low ovarian reserve, does that also mean that you will have a lower implantation rate? So the ovarian reserve is just telling us, as I said before. So the previous question was specifically to AMH, but ovarian reserve is a bunch of tests that include the AMH that was asked before, the anti-Mullerian hormone level. We also look at follicular stimulating hormone level, FSH, which is what I told you, your brain signals to the ovary to start growing follicles. The ovary, remember, responds with estrogen, so we can look at FSH and estrogen in estradiol, which is an estrogen, in conjunction with each other. And then we can also look at your antral follicle count. Your antral follicle count is basically at the beginning of your cycle. We will do an ultrasound to look at the ovaries and see how many follicles you have developing. Depending on your age or your background history, the number will vary. And we can use these 3 different tests in conjunction with each other to determine what we call your ovarian reserve. Now, your ovarian reserve basically really truly tells us what your response will be to treatment. It doesn't tell us fertility, and nothing really 100% tells us fertility. We have had older patients beyond the odds with low AMHs, older in age, get pregnant with their own using their own egg. Likely we have also have had younger patients with high AMHs and many follicles developing with, you know, still struggling with fertility. And that's where, you know, infertility help, where reproductive specialists and intervention comes into play, because either one of the spectrum, you know, you can have fertility happening or not happening, either end of the spectrum. There are young patients who are infertile, there are older patients who are fertile, okay? So I always say that, in medicine, we have no 0 100%. Nothing is 100% guaranteed. Nothing is 100% not guaranteed. So 0 to 100 really doesn't exist. The probability always lies between there. Just some patients are much closer to 100 and some patients are much closer to 0. But once you're not at 0, you still have a chance, okay? Now, as I said, the ovarian reserve is telling us the ovaries response. When we're looking at implantation, meaning if you have an embryo, and your previous question is about a euploid embryo, like if you have a genetically normal embryo, it doesn't, now the ovarian reserve doesn't play much of a factor in terms of implantation. Implantation actually now is dealing with your uterus. So your uterus, the lining of the uterus, how thick you are able to get the lining of the uterus, the composition of the cells of the lining of the uterus. For example, in the beginning of your menstrual cycle, when you're producing a lot of estrogen, because you're producing all those follicles, the estrogen signals to the uterus to grow that lining, okay? And in the ovary, you have what we call the follicular phase, and simultaneously in the uterus, we have what we call the proliferative stage. Proliferative because the cells of the uterus are getting bigger and bigger, and that lining is getting thick. That's the beginning. Once you've ovulated, the ovulated follicle, now called the corpus luteum, is going to produce progesterone, and the progesterone effect is now to cause all this lining cells to secrete glycogen storage granules, secrete factors, secrete substances that make the environment in the endometrial lining, the lining of the uterus, nice and favorable for when the embryo is going to implant. So the quality of the lining is also a factor to play, because if you have that lining grow nice and big because of estrogen, but you've never ovulated, you've never secreted progesterone. For example, in polycystic ovarian syndrome, these women have lots and lots of follicles. Because they have lots and lots of follicles, guess what? Their lining is extremely thickened. However, most times they don't ovulate. Without ovulation, that lining gets really nice and thick, and you'd be like, oh, a thick lining, that's perfect for implantation. Except no, it isn't, because without ovulating, well, one, they don't have the egg, but beyond that, because let's just say we took the beyond not having the egg, because you didn't ovulate the egg out, the lining itself is also not favorable, because without that progesterone effect, you don't have these secretory granules. You don't have the secretory phase where all these granules and growth factors and factors to help with implantation occurs. So does a diminished ovarian reserve equal to having a low implantation rate? No, because though the ovary and the uterus communicate and respond to each other, they are two separate organs, and some patients, their problem would be just within the ovary. So once we're able to overcome and get embryos and get euploid embryos, which means that we have 46 chromosomes, the normal number of chromosomes in the embryo, once we're able to bypass that, then at the end, now it's up to the uterus. If your uterus is proliferating well, if in the secretory stage you have a nice environment, a nice stable environment for the implantation of the embryo, then it doesn't matter that you had a diminished ovarian reserve. Now you should have a great chance still to get pregnant, because the ovarian, we've overcome that and you have embryos. Okay, I hope that answered. What is your opinion on IUI for women with poor egg quality, as well as for women that have low egg production? So if you have, it's difficult for you to say poor egg quality. That's difficult to know unless you've had egg retrievals before, and you've had like degenerated eggs, meaning that we see the remnants of what was an egg, but it's already like gone and degenerated. Or if you had you've made embryos before and the quality of the embryo was not ideal. Because egg quality, we can only determine, when we have egg, when we have sperm, we can only determine the quality based on physical characteristics. We can't tell you genetically that your egg is poor quality egg unless it's an abnormal shape, or it functions abnormally, or you can see like the nucleus and it's double. Mature egg, actually, we shouldn't even see nucleus initially. So if for some reason, let's just say you've done a process before and you know that you have a poor egg quality, then it may be difficult to do IUI if you have this prior knowledge. IUI really is done if you think that in terms of the female reproduction, that most things are working. You have to have open fallopian tube. You have to be able to ovulate, and we can actually help you. We can give you medication to ensure you ovulate with an IUI procedure. You have to be able to release that egg. The process in the woman should be more or less working, and we can do little intervention to increase the follicle to like 2, 3. We don't want too many because then it's at risk of multiples. We can give you medication to make you ovulate. And IUI really helps if there's like a small problem in the male factor. If it's just a little diminished male factor, it can't be like a grossly abnormal male factor, or else it also would not work. So IUI is just like, your little boost, just because, maybe you think there's a small problem in the male side of things, and IUI will wash the sperm. That will concentrate the good sperm. You centrifuge it, you concentrate the good sperm, and you put that directly in the uterus. But in terms of the woman, you would have to still be able to produce a follicle, ovulate that follicle. The fallopian tube have to be clear to pick up that egg. The egg has to make its way through the fallopian tube, which is where the sperm usually meets the egg and fertilizes it. And your uterus and endometrium has to be in an ideal environment for implantation to occur. So if any part of that journey is not working, or there's a roadblock, then IUI would not be the best option, and you would probably need IVF intervention. Can you have PCOS and still ovulate? Yes, you can have PCOS and still ovulate. However, the majority of patients with PCOS will not ovulate, and it tends to be the lack of ovulation that contributes to the syndrome, or like the characteristics of the syndrome. So in polycystic ovarian syndrome, you produce a lot of follicles, so your reserve tends to be higher, your AMH levels tends to be higher. So you're producing follicles. Some follicles will get big, but most times you will not ovulate, and hence that's the major problem. So one of the first things that, as an intervention before IVF is that letrozole can be used. Before, we used to use Clomid. Letrozole is seen to be superior medication, and that will help, produce the follicles, as well as that we can also give you medications to help you ovulate in polycystic ovarian syndrome. So in terms of polycystic ovarian syndrome, majority of times the problem is ovulation. It doesn't mean that everybody with this syndrome doesn't ovulate. Also, it doesn't mean that you don't ovulate all the time. Some patients will ovulate. The frequency of ovulation is just less. So there is a possibility to ovulate with PCOS, but most times most women will not ovulate, and will not ovulate frequently, and that is what causes the variability in the length of your menstrual cycle when you have PCOS. So let's just see another question. I did an ultrasound on the third day of my cycle. I had 4 to 5 follicles on each ovary respectively. Is this normal? Well, what is determined to be normal? It varies. It depends on a lot of things. It depends on what your reserve is. It depends on what your age is. It depends on, those two main factors: what your ovarian reserve is and what your age is. So 4 to 5 follicles on each side means that you have approximately 10 follicles in total. Remember that through a natural cycle, those 10 follicles will still boil down to like 1 becoming dominant. But if you were to do an intervention, take medication to try and stimulate as many of those follicles as growing, then those we have potential to get 8 to 10, because you said about 4 to 5, so 8 to 10 follicles becoming dominant with intervention, and that is depending on your age, a number that it's okay to start off with. Normal is different for everybody, different for everyone, every individual, and that may be your normal. It may not be your sister, cousin, or mom's normal, but it may be your normal. And just working with what you have, we can help increase what you have based on what your different factors are. So based on your AMH, your antral follicle count. So what you did is what we call an antral follicle count. On day 3, looking at the follicles, and basically what is normal for you, what is normal for someone else would have to be something really individualized. If you want, you can book a free consultation up to the 15th, phone or video consultation, and then any specifics that you want to discuss about your personal case, we can do there. We are very limited to discuss individual cases on a forum like this because we do have HIPAA laws and different laws that we have to abide to. So I wouldn't want to put personal information out there. But if anyone has specific questions about themselves, do remember that up until the 15th, New Hope Fertility is offering free phone and video initial consultations where we can go in depth in terms of your baseline fertility, your options that you have, what the next steps could be, how you can get yourself prepared. I know that right now, it's a very trying time for all of us, for every single one of us. We have our own personal battles. We have our own little stories of how we're dealing and coping with COVID-19. Many people don't want to come out their houses, which is good. Do not. If you don't have to leave, stay home. But at the same time, I definitely would say that if you want to talk personally, individually, then book a consultation with us. And, we have several doctors. You can go on the website, newhopefertility.com, and you can read the bio and choose, which doctor you'd want to consult. I am Janelle Jackman if you want to choose me, but we do have several doctors, okay? So definitely book a consultation, phone or video. I encourage phone and video for the initial consultation during this time, please, because it will give us an ability to safely discuss all your questions, all your concerns, all your personal stuff at a safe distance for us as well as yourself. And then once ready to start, as I said, we do have a home IVF option that can basically help in terms of like reducing the amount of times that you have to actually leave. So we have many options that are good options for you. So anything specific, just book that appointment and we can discuss further, okay? Can New Hope test for miscarriage risk? Similarly to fertility risk, it's difficult to tell you your miscarriage risk. Age does have a part to play, just not nearly as much as it does play in terms of your eggs, but age. But therefore, we also look at, for example, if you have any genetic abnormalities in yourself, if the embryo is abnormal, provided you tested it, then we can also like predict in terms of like, your chance of miscarriage might be higher, but it's not an exact science to say that, you are this age, your endometrial lining is this thick, and this is the background of this, and therefore your miscarriage risk is X. It's not as easy as saying, they're not like precise, exact tests that we have that I can tell you, yes, well, I know that this is your chances of having a miscarriage. It's definitely not that easy. We can just use different factors that may come up in different testing, particularly if there are any genetic abnormalities to the embryo, or if you yourself has any background problems, and then use that to determine. But if you want like global numbers, obviously this is not individual numbers, global numbers, it's estimated, and this was like a study done like in 2015, which is the last time I think they really had this published data. So in terms of if you're a woman less than 35, then your miscarriage risk is about 15%. If you are at age 40, so from 35 to 40, it's about 29%. And then for women older than 44, it's about 65% your miscarriage risk. And these are global numbers when they have looked back at several women over time and their ages. But obviously the risk will be more individualized depending on your background history, depending on the quality as well as the genetic testing of your embryo, depending on your lining, depending on if you've had miscarriages before, because your miscarriage risk increases if you've had miscarriages before. Depending on if there's any abnormalities of your uterus, depending on if you know, have any underlying medical conditions. So like it's known like diabetes and chronic hypertension could increase these risks. So it's not as easy to, you know, just do like a blood test and tell you that this is your risk, but we can use different factors to help you determine what it may be. But just know that these are not absolute numbers and it's not 100% what is going to be your personal risk. So let me just see if I missed any questions. I think I've been doing pretty okay in answering them as I saw it. I hope I didn't miss anyone. If I did, you can retype it now. From glancing, it doesn't look like I missed any. So we're getting close to now. I just wanted to like touch on one more thing, unique test that we've recently started to offer in New Hope Fertility. So we just started to recently offer. So we have tests for the embryos to test for their chromosomal number, which is called aneuploidy. Okay, and we can do this in a non-invasive format, and we can do it in a traditional biopsy way. Remember this diagram if you're here earlier with me. The traditional biopsy is that we take a little bit of the cells and biopsy it and send it off. The non-invasive way is that we use the medium that your embryo is growing in. So we can test for the number of chromosomes. It should be 46 in your embryos. We can also test if you have like a specific disease, for example, cystic fibrosis. We can test to see the risk of the embryo, if the embryo has the gene, for cystic fibrosis. So we can actually test that. And recently we started to test, we do a test called PGTP, and this is called polygenic diseases. And this is offered by a few centers. We, I think, are the only center in New York that offers it. And PGTP is basically polygenic disorders. It's disorders that's caused by multiple factors, not just like one genetic abnormality, but a contribution of several problems. And Genomic Prediction is the lab that we are working with to do PGTP. So you can actually now test, apart from knowing that your embryo has the normal number of chromosomes in it, which is 46, and apart from also telling if you have a specific problem like cystic fibrosis that you want to test for, we can give your embryo a polygenic risk score to see the if your embryo may develop a problem later on in its, well, once a child has been born, later on in the child's life, we can give you a probability. So we can actually test to see if your embryo may have type 1 or type 2 diabetes in the future. We can test if there may be a risk of developing coronary artery disease. I'm going to read the list that I have here. Heart attack risk, hypocholesterolemia, hypertension, breast cancer, testicular cancer, prostate cancer, malignant melanoma, basal cell carcinoma, intellectual disability, and idiopathic short stature. Though we will tell if the embryo has a risk of intellectual disability, we will not do the converse and test for IQ. So we wouldn't tell you its ability intellectually, but we can just tell you if it may have intellectual disability. And this test is best used for patients who may have several embryos and they want to categorize how to use several normal euploid embryos. Euploid is 46 chromosomes, and they may want to categorize how they're going to use these embryos. For example, which embryo should be used first, second, third, depending on how many children they plan to have and depending on the success of the transfer. So it helps us categorize embryos that way. The test is not for everyone. Not everyone will want to know the embryo risk score, and not everyone may have the ability to really want to know it. For example, if you only have one embryo, knowing the risk, would that change your outcome? It may not, because you have one embryo, so you may still transfer this embryo. Also, depending on the risk score, it is not a reason to discard an embryo. It just gives you an idea of probable futuristic complications that may happen. Remember that genetic is one thing, but environmental factors also play a role in whether certain diseases do occur. So it's not to say that, you know, it's 100% that if you do this test and you see that your embryo has a high risk for diabetes, that your child will 100% get diabetes, but you know the risk at least. So that is one other test that we do offer. So I see, is it true that pregnant women have more risk with the COVID-19? So, in terms of COVID-19, it's very debatable. Oh, I see I have 26 seconds left, so I'm going to answer this really quickly. It's very debatable. It's a new disease. It's happening in process in time right now. We haven't seen anything statistically conclusive that showed that pregnant women are more at risk for suffering any diseases or being susceptible to COVID-19. But we do tell you to take precautions with respect to COVID-19 in general. We want everyone taking precautions, cover your face, wear a mask if you have it, or any